Okay, students, welcome back then in the graduate course on bioethics in the program of cellular and molecular biology at St. Thomas University. Before we go into today's lecture, I want to put you up to speed and date on a little booklet that is our textbook, right? So I forgot to do that at the beginning. It's in the syllabus anyway, but it's called Ethical and Religious Directives for Catholic Healthcare Services. And if you just punch the first three words, ethical and religious directives, well, first four words. It shows up. Okay, it's from the United States Conference of Catholic Bishops. And it's very succinct. It's a little booklet that is even formatted vertically in half a page, so it fits nicely in a jacket pocket or something like that, right? Or a lab coat pocket. And it's very handy to have. It's very succinct, compressed, and it covers the bioethical issues at the beginning of life and end of life, and then other healthcare issues. Let me go through it for a moment, just quickly. You can download it for free, all right? And make sure you get the 6th edition. So you can just put ethical and religious directives in Google or a search engine and it will show up. You can download the PDF for free. It's also been translated into Spanish if you ever have Spanish-speaking patients or someone like that, or colleagues, all right? Or if you want to share it with family and friends. And it has 6 parts, and the parts are like mini chapters, mini chapters, because each part is 2-3 pages long only, and it's even half a page format, so very, very short, but compressed. And let's see, so the first part is the social responsibility with healthcare. The second part is pastoral and spiritual responsibility. This has to do with mostly the sacraments and the fact that patients, not only Catholic patients, but patients of any religion and even no religion, have a natural right to ask for their spiritual leaders. Part 3, here the other 3, 4, and 5, the other 3 parts are a little more clinical, if you will. Part 3 is a doctor-patient relationship, okay? Doctor-patient relationship. And then 4 is a beginning of life issues. 5 is end of life issues, those who are seriously ill or dying, right? And then finally, part 6 is on cooperation and the limits of cooperation with other non-Catholic institutions, or in this case, so this is at the institutional level, but a lot of it can be translated at the individual level. And part 6 essentially is about cooperation, formal and material cooperation with unethical procedures and the limit of that cooperation, okay? But basically, for our purpose, part 4 and 5 are the most informative. Of course, covered 4 already, so you'll find a lot of things there on contraception, abortion, in vitro fertilization, and natural family planning. And now we're into part 5, okay? So I ask you to please download it. You can see from part 5 to part 6, it's only 3 pages, so it's very brief. And each part is subdivided into 2 sections. The first section is an introduction to each part. And the second section is a number of directives. Directives, and that's why it's called ethical and religious directives. In other words, it's typically a paragraph or 2 on some statement, okay? some bioethical statement. For example, we'll see a couple today with regards to ordinary and extraordinary means of life support. There's an ethical obligation to do ordinary means of life support, and there is no ethical obligation to do extraordinary means of life support. So those are two directives, and they're numbered sequentially from 1 to about 70, depending on what part one is on. So let's go to, let's see, part 5, that's 3. There we go, part 5. So each one of these parts, which are like mini chapters, first has an introduction, which is about 1 page, and then it starts with the directives. I don't know how big that is showing on the screen. Yeah, you can see that, right? And so on part 5, at the end of life, issues at the end of life begins with directive number 55, and it goes through 60 something, 66. So you see it's 11 directives, okay? And we refer to this little document because the title is so long, the title is almost longer than the document itself. Ethical and Religious Directive for Catholic Healthcare Services, 6th edition. For short, we just call them ERDs, the ERDs, all right? Ethical and Religious Directives. So whenever you see that abbreviated in caps, ERD, that's what they stand for. And so we put ERD 55, ERD 57 as a reference to the particular paragraph. And I mentioned that because in today's lecture, I'm going to get into some of these paragraphs and start using them. They are nice and succinct, like I say. Okay, so please download it, become familiar with it, and it's a handy little tool to have. All right, today we're going to look at these two main issues, the determination of death, and then ordinary versus extraordinary means. So this ordinary and extraordinary means of life support is going to parallel a little bit the language that I was using with assisting or substituting vital organs, all right? But this is focused more on procedures themselves. So we'll try to address that. First, we need to look at the determination of death because that's kind of where we left off last time, meaning that we were looking at vital organs, and then I was mentioning where vital organs begin to fail irreversibly, then the death process has begun. Sometimes it's pretty dramatic, like in a stroke or a heart attack. Other times maybe subtle, as in the case of a cancer or renal failure. But nonetheless, if a vital organ begins to fail irreversibly, then we can say that the death process has begun. And it may take a few weeks, a few years, we don't know. Certainly, typically, slower than the beginning of life process, right? So the determination of death is important, not only for organ transplants, but just simply to then dispose of the corpse, of the cadaver, because like I mentioned, it has ethical, aside from the ethical implications, it also has legal implications, not only inheritance and things like that, but actually the funeral home cannot bury a corpse, cannot work on a corpse unless there is an official declaration of death. And who determines whether a person is dead or alive in this country and in many countries of the world? It has to be a clinician, a medically competent professional who has precisely the competency to address this, okay? Now, I can tell you that in the United States, up until the 80s, there was no uniform determination of death. It was up to each state. The criteria and the standards varied from state to state. And so literally, one person could be dead in one state and alive in another state, depending on what the issue was, all right? And that obviously causes problems for many reasons, okay? So there is a commission in the United States that is a commission that looks at uniformity of laws across states for issues that affect the whole nation, but that each state has the authority and the right to regulate. So let me give you an example. The highways, the interstate highways, right? They typically start with an I for I-95. The I stands for interstate, all right? So interstate highways in the US, they go through different states. That's the wording, interstate. However, it is the responsibility of each state to maintain that section of the highway that is going through their state. And that's why if you get on I-95, it's very interesting because you can start down here in downtown Miami and go north and end up in Maine in the border with Canada. It goes all the eastern seaboard, all right, eastern United States. Eastern must be about a dozen states that it goes through. And in some states, it is very well maintained. I-95 is nice, fairly new asphalt and so forth. And in other states, it's full of potholes and old asphalt. And that's because it has to do with the state budget that is allocated for maintaining that segment of the highway. Okay. Also, so for example, on an interstate like that, the speed limit, and even things that may sound crazy for us at this time, but it's up to each state to regulate whether the traffic is going to be on the right-hand side of the street or the left hand, as it would be like in Great Britain that they drive on we say they drive on the wrong side of the street. Well, they think we drive on the wrong side of the street, right? Who's right, who's wrong. And also the meaning of the different lines between lanes, if it's a continuous line or if it's a segmented line, and if it's white or yellow, it has different meanings. But it's important, it's essential that it has the same meaning throughout the different states. Otherwise, it's going to be chaos, okay? And so this commission is in charge of making sure that there is uniformity among these laws, state laws, that impact other states, right? Or even throughout the whole United States. And this was one of the cases that there was no uniformity on the declaration of death up until the 80s. And so this commission that looks at issues like that, they got on the ball and started getting, first they got consultation from two main professional organizations in the US that have a stake in the declaration of death of a patient, which would be those two main organizations, professional organizations that have a stake in the declaration of death of a patient. I can tell you, give you a hint, one is medical, the other one is legal. AMA, American Medical Association, has a stake in who's going to be declared dead or not, and the patients, right? Because the patient is dead, they can't bill anymore for coding and all that. And the other one is the American Bar Association, so the ABA. In other words, the lawyers. They also have a stake in knowing whether the person is dead or alive for many legal reasons, okay? So in consultation with the AMA and ABA, this Commission on the Uniformity of State Laws came up with not one, but two declarations of death, either one of which is acceptable medically and legally. Right? And it is known as the Uniform Determination of Death Act. And so the acronym is Udda, Udda, or Udda with a double D, Uniform Determination of Death Act. All right. So this is the commissioners that I'm telling you about, the National Conference of Commissioners of Uniform State Laws. They have a long title. They consulted with the AMA, ABA. And also there is a President's Commission on Bioethical Issues. And each president puts their own commission together. Okay. So they had a stake in this too and gave some their opinion and some feedback. And the end result is this, like I say, the Uniform Determination of Death Act, which now applies throughout all states. This commission had to go to each state legislature and get it approved. And that was done through the 1980s. And all 50 states have now approved this declaration of death, which, like I say, there are two possibilities, two alternatives. Either one is legal and clinical and valid, if you will. So one focuses on heartbeat and respiration, and the other one is a neurological criteria, focuses on the brain and the brain stem. So the first one is the irreversible cessation, cessation of heartbeat and breathing. And that is also known as the standard or the classical or the traditional declaration of death. And typically no instrument is necessary. That's why it has to be a clinician, because even if there's a faint pulse, they can feel it, right? So train for that. Or if there's even a faint heartbeat, also they can feel it. So no heartbeat and no breathing essentially is the standard, classical, traditional determination of death. And no instruments really are required to do that, even though typically a stethoscope to listen to the heartbeat, many doctors will use that. And the other one is the neurological criterion, which is irreversible cessation of all brain functions, including the brain stem, And that's why when I was listing vital organs, I listed separately brain and brain stem. You see, because we can have the case where the cerebrum, the brain, is dead, as in PVS, but the brain stem is alive. And so a patient in PVS may still be breathing on their own and heartbeat on their own for years. So they're not really dead. Okay, but the cerebrum is dead. And so it has to include the brain stem, the medulla oblongata underneath the actual brain, because the brain stem takes care of what? Involuntary motion, involuntary activity of the body, precisely the heartbeat and the breathing. You know, it's a good thing, because then I don't have to tell my heart, beat, 60 to 80 minutes, 80 times a minute. And I don't have to tell my lungs, breathe, either, an average of about 20 times a minute. You know, think about overnight, for example. So it's a good thing about the autonomic nervous system that is running these organs that are vital organs. Okay, so either one of the two, either the traditional determination of death or the neurological criterion, they're known as criteria, is acceptable, all right? Now, here, it's now historical, but at the time it was delicate, because some were advocating for just what is known as partial brain death. And partial brain death will not include the brain stem, whereas total brain death includes the brain stem, okay? And it was delicate because a few people or a few clinicians were advocating for just partial brain death. That was sufficient to declare a person dead. Who would have like a vested interest in that? What? In partial brain death. A person who would be, for example, PVS would be declared dead because their cerebrum is dead. The brain is dead, but the brain stem is still functioning. Who do you think would have a vested interest in that kind of declaration of death? The people who work on transplants of vital organs. Because with a partial declaration of death, I can actually pull out a beating heart, a living heart, or living lungs, right? You see? But in fact, the person is not really dead. When I pull out the heart, that person's going to die. But the person is not really dead until then, okay? And therefore, the neurological criterion included total brain death, all right? And that was a big contribution from the AMA, for example, that they said, no, if we leave out the brainstem, then we're actually, and we take out vital organs, we're actually going to be killing these patients because they're not dead. All right, so that was a critical point there. It's now historical. It was resolved, thanks be to God, in the 1980s, and this is legal now. So at least in the United States, partial brain death is not really dead. Luis?
Is there any other country where it differentiates from that?
I don't know. I don't know. But I do know that, euthanasia is a little different, actually. But no, I don't know in other countries. I just haven't studied it. But at least for the US, it has to be total brain death. Okay, let's move forward then. Looking a little bit, now that we have an official declaration of death, and it will be a clinician who makes that declaration, right? Again, I want to say that the average lifespan in the United States is about 80 years of age, more or less. Well, 79, yeah. In men, it's about 76. In women, 81. For some reason, women get to live longer on average. Some people think that it has to do, actually, the metabolism of women is more complicated, of the female body, and maybe they're more resilient a little bit. And some people think that it has to do with childbearing, the capacity for bearing children that actually makes them have a longer life expectancy. At any rate, the combined doesn't really mean anything. That's the average between the two, but we're not a combined. We either male or female biologically, and therefore these two numbers are a little more informative. I say this because in the case, for example, of CPR, right? It's good to know what is the age of the person on average, whether they have essentially lived a full life or not. It doesn't mean that we're going to start disconnecting people women who are 82 years old or men who are 77 years old. You know, it doesn't mean we disconnect them, but at least if they are that age, we know that on average they have lived a full life. Okay, it's just to have like a guiding post, if you will. But I also want to point out these two values, which are a little subtle to understand, okay? But I think it's very important for us to be able to distinguish between killing or allowing to die. It's another critical distinction at the end of life, because we will know that sooner or later, all our organs, some organ is going to fail, some vital organ is going to fail, if not all of them. All right, and it's called systemic shutdown. At some point, all organs are going to fail. And so medicine has its limits. Fundamental value, but not an absolute value. It's very important. And I'll tell you where it's very important is in trying to get the family to let go of the dying patient or the dying relative. Because sometimes the patient may be unconscious, but the family members don't want to let them go. And so the patient is lingering and lingering. At some point, we're actually not prolonging their life, but we're prolonging their death, okay, which is not a good thing. So why is life a fundamental value? Because we should always respect life. We should always respect human life, all life, but in particular human life, because it is a fundamental value. In other words, none of us has to be alive. Life really is a gift we're given with life. And then what we do with our life is our gift back to God. But it's not an absolute value. And the reason for this is a little philosophical, but if life were an absolute value, then we will be obligated to preserve all human life at all costs. You see, and then what happens with that scenario is that we wouldn't be able to allow people to die because it's an absolute value. It has to be preserved at all costs, which is really not rational, not reasonable, not logic, right? So that's why it's not an absolute value. Yes, sure, but even that, it's just that simply clinically, we don't have the means to keep everybody alive, everybody who is dying. In other words, medicine does have its limits, right? Medicine does not cure everything. And so that's what I say, it's a fundamental value, meaning that all human life should be respected, right? But not absolute value. And the distinction is a little subtle, it's philosophical, but it's important to know this distinction. Because if it were an absolute value, then we would have to preserve that life no matter what. Even if the patient is dying, intubate, keep doing all the procedures necessary, all right? We just can't allow this patient to die, even though the organs are failing irreversibly. Okay. We move forward then. Also, some distinctions here with regards to management. We're trying to manage the pain and suffering, which again, these are not exactly the same, pain and suffering, but many times they're used together or interchangeably, especially in the medical profession. We'll talk about pain or suffering interchangeably, but when you think about it, I can give you scenarios where some people may be in pain but not suffering, or vice versa. They may be suffering but not in pain, all right? For example, let's say it's a young couple, they're having their first child and she's in labor. So who's in pain? She's in pain. But who's suffering? He's suffering because he's watching her being in pain, you know, but there's nothing that's hurting physically, physiologically to the husband. And she may be in pain, but not necessarily suffering. I mean, after all, this is their first child. For years, they've wanted to have children. So she's actually with joy in the midst of those labor pains, okay? And as soon as the kid is out, there are endorphins and hormones that kick in that totally relax her, and that the labor pains are gone within minutes. It's just amazing how intense that could be for hours and then just dissipate within minutes after the labor, all right? And then she is neither in pain nor in suffering because now they have the child. So you see, pain and suffering not necessarily the same. Pain is more at the physical level, physiological level. Suffering is more at the psychological or spiritual level. However, as healthcare professionals, or if you're going to be involved in healthcare, you have to be aware of both because each one has its own professional too. So what do you think for pain management, strictly, who is the competent authority for pain management? They're both clinicians, but it would be a medical doctor, maybe a specialist or a generalist, but it would be a medical doctor. Whereas for suffering, if a person is suffering but not really in pain, who's a competent professional? It's also a clinician, but he's going to be a psychologist, a counselor, or a psychiatrist, right? Dealing with suffering more than physical pain. Follow? And so there are different types of medications also that apply physically or psychologically. All right. Also, in the analysis of the diagnosis and the prognosis, you know, the current state of the patient and the hope of recovery, we have to do this benefit burden analysis to see, to try to help the patient figure out if the treatment, the proposed treatment protocol is worthwhile or not, all right? If they have cancer that has metastasized already and it's invaded several vital organs. I have a friend of mine now who's in the hospital. He's trying to get released because he has metastasized cancer. There's really no cure, and he wants to die at home. So what's the proper protocol there for him? What is the proper indication? Not to go through another round of chemotherapy or something like that. It's going to make him nauseous, and there's no way that the chemo is going to help. So really, he should shift to hospice, which is just comfort care, all right? And no aggressive treatments because they're futile. And so we have to see what are the benefit and the burdens of any particular protocol with regards to the particular condition, to the diagnosis of this patient before us. So all of these themes are interrelated, and sometimes family and friends can't really distinguish between them. It's just a jumble of things. They're anxious because their loved one is hurting, and they can't figure out how to help. So we need to help them with a clear mind and walk this scenario to come to the proper conclusion. All right. Again, in the area of terminology, not always does it match up the terminology that we use in bioethics and the terminology that is used by clinicians, all right? So for example, in bioethics, we talk about ordinary or extraordinary means of life support, which is also, we talk about proportionate or disproportionate means of life support. But for clinicians, they're going to be talking about whether it's standard medical practice or it's an experimental treatment. That's their language. So for example, I go back to dialysis because to me it's one of the most clear one where we can see the discrepancy between the two mindsets, whether it's a clinical mindset or a bioethical mindset. Dialysis, do you think it's standard of care or is it experimental treatment? Standard. It's been around for decades, you know, it's been perfected. And so automatically, any clinician, renal failure, dialysis. End of discussion. But for bioethicists, we're going to be talking about, well, is that ordinary or extraordinary means? It depends on each patient. For the clinician, this is standard medical practice. You should really go on dialysis. In fact, the medical doctor may be suable if he or she does not recommend that. Okay. However, the patient may decide, no, in my particular situation, that is an extraordinary burden. Okay. Or even if they have been on the procedure for X amount of time, at some point, what started out as ordinary now becomes extraordinary, even though it's still the standard of care. So we have to try to bridge that gap of language sometimes, and that's why I introduce the alternative of assist and substitute, because I think that both bioethicists can understand that distinction between assisting or substituting, and the clinicians also, assisting or substituting, as long as we're talking about vital organs. All right. I think that language of assisting and substituting, I don't know, maybe it's just me, but I think that it helps to bridge this gap of language, of concepts between bioethicists and clinicians. All right, so here is an example of the ERDs, and 56 and 57 are the ones that apply to what I'm talking about today. So ERD 56, a person has a moral obligation to use ordinary or proportionate means of preserving his or her life. See? And then it goes on in the second sentence to define what are proportionate means. Proportionate means are those that, in the judgment of the patient, offer a reasonable hope of benefit and do not entail an excessive burden. So you see the language, benefit burden analysis, or impose excessive expense on the family or the community. Now, well, let me read the other one first, and then I want to go back for a detail here that is also important. So if ERD 56 talks about what is ordinary means or proportionate means, then the following one is going to talk about disproportionate or extraordinary means. All right, and it's going to say essentially there is no obligation. So a person may forego extraordinary or disproportionate means of preserving life, And then again, the definition, disproportionate means are those that in the patient's judgment, again, do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or community. So they go hand in hand, right? Now, I want to return then this in the patient's judgment, in the judgment of the patient, because it's not the judgment of the doctor, it's not the judgment of the family members either, the spouse or the closest relative, right? It's the judgment of the patient. So this makes it very subjective because one patient may decide dialysis to be fine and another patient may decide dialysis to be a no-no. And who's to say? We have to respect the opinion of the patient, but as long as it is reasonable. Now, what happens when the patient is being unreasonable? That's really the challenge right there, okay? When the patient is being unreasonable. And I can tell you when the patient is unreasonable, everybody gets frustrated. The doctors, the family members, the bioethicists, you know, this is one example. Let's say a blood transfusion. Would you think that a blood transfusion on average is standard of care or experimental procedure? Blood transfusion, experimental? Let's say if a person is anemic, standard of care. A pint of blood. Person anemic, you know, pint of blood. I know it's getting harder and harder to get the pint of blood because fewer and fewer people want to donate, right? But still, as far as the procedure itself, standard of care is an IV and you're done. So, and yet we know that there are some communities, some religious communities that do not accept a blood transfusion, right? The Jehovah's Witnesses is one of them. It's a very classical case. Could be Scientology, yeah. Mm-hmm. And so their thing is that they believe that the soul is in the blood. And so when they receive a transfusion, obviously that transfusion came from somebody else, then they're receiving the soul of that person in them, and that's an abomination, all right? And therefore, on religious grounds, they cannot accept that transfusion. Well then, that presents a dilemma for the doctor, right? Because they know that this pint of blood can save the life of the spirit. Let's say, again, a woman in labor lost a lot of blood in the childbearing, and she's dying from internal bleeding. She needs a pint of blood. But if the patient says no, it's objectively speaking, it's unreasonable, okay? And yet, we have to respect the judgment of the patient. Now we should try to, what should we try to do with the patient? We should try to reason with the patient as much as possible. Mm-hmm. And I understand that some Jehovah's Witnesses have worked out a way somehow to deal with this and to accept a pint of blood. Okay, I don't know exactly what kind of reasoning they're using, but I've heard that recently this is coming up, and therefore they have found a way to maneuver theologically around it so that it's not that offensive as they thought of before. That's a classical one. Anyway, so this whole issue reasonable, and you see that reasonable appears on both, right? If the patient is being unreasonable, we should try a dialogue with that patient, try to get them to reason, to think what's best for them, really. But if they still refuse, we have to respect the judgment of the patient. And in fact, the patient's judgment is protected by law. So even legally, patient cannot be forced. Imagine forcing a patient into a medical procedure. It's not going to happen, right? Okay, so these ERDs, you see, they're very practical and they're very succinct. So it's good to have them handy that way. So returning to the concept from last class, assist or substitute. Well, assist would be ordinary or proportionate means, whereas substitute could be extraordinary or disproportionate means. It doesn't mean that they should not be done. I remember one of the previous groups when I was teaching this, someone at some point in their summary said, well, if it's substituting, it should not be done. No, it doesn't mean that. It means that it doesn't have to be done. There's no obligation, but if the patient wants to go, because medically it's experimental treatments, and experimental treatments at some point do work, right? May have a low chance of success, but they have some chance of success. So the patients, in fact, some patients voluntarily submit to experimental treatments, to trials. They're known as the human trials, right? Which is the last phase in the development of a protocol, whether it be a medication or a procedure or something like that. So it doesn't mean that in substituting that it should never be done. It means that there's no obligation to do it. Different thing. So when to withhold or withdraw life support in the estimation of the patient when it is an excessive burden and not of sufficient benefit. Therefore, at the end of the day, we're left with answering this question and the critical distinction between killing a patient. We should never kill a patient, but we should really allow the patient to die, because sooner or later, all patients are going to die, right? So there's a little saying attributed to Francis of Assisi, and Francis of Assisi was an Italian saint in the Middle Ages who was a great lover of nature, right? Including human nature. And there's a little saying attributed to him. He would say, he would talk about brother sun and sister moon and mother earth, like he was related to all living creatures around, even non-human. And he would say, let us be reconciled with sister death, because she always wins. So be reconciled with sister death. And I tell you, it makes a lot of sense. What I found over the years, decades of visiting people at the hospital and so forth, is that some people are just afraid of death and they don't want to let go, and they're so anxious, and then they make everybody else around them anxious too. But we have to face the reality that sooner or later it's going to happen. You know, now you are young people, and hopefully it will be later rather than sooner. But so for some of us who are over half a century old, it's getting to be sooner and sooner. Therefore, we have to come to terms to that, that at some point, not that we wish death, we don't wish it, but we accept it, it's going to come. And that's where also I think having a faith, a belief in something after life also makes a lot of sense and brings a measure of hope and peace, because we know that in the end, this is not all there is, right? Like the little song, is that all there is? Then let's keep dancing. You heard that song? That's from my time. Yeah, to a fire. Yeah. Exactly. All right, so you see that ultimately appealing to some belief in the afterlife can also bring a lot of comfort to the dying person and to the family members who are dealing with that loss. Okay, it doesn't make it any happier, but at least there's a sense of peace and comfort that we're all here for a time. Okay, so well, that's all I have for today. Let me just review here the two definitions of death, then dying process within the concept of faith, ordinary, extraordinary means, and then this critical question, killing or allowing to die. We should never kill anyone. I'm talking in the context of healthcare, you know, not in the context of war or self-defense. But we should allow patients to die. Medicine has its limits, and at some point there's no more cure. Remember, care always obligates, all right? We'll talk about other scenarios where how to provide care, even if there's no more cure for the patient, and what is the minimal care for any human being to preserve their dignity and to respect their fundamental right to life. Also, you'll see the euphemisms. I've talked about euphemisms before because at one point we're going to talk about physician-assisted suicide and euthanasia. And the pro-euthanasia movement uses this phrase, okay, the right to die, the right to die. And it's stated that way, yes, we have, if we're alive and we know we're going to die sooner or later, then we should, it's a natural right to die, right? Don't deny me my right to die. However, it's just that the way it's being used, they're not really advocating for a right to die, they're advocating for a right to be killed or to kill themselves. And that's the distinction, but people don't pick up that distinction. They talk about the right to die. So again, words are meaningful and are powerful because they move societies. And we have to be very careful in bioethics. We have to be able to distinguish and cut between, as I say, joint and marrow, and make these distinctions that other people don't pick up, all right? Okay, well, let me see. Any questions or comments? Alisa, Anome, anything?
No.
You can follow along, all right. Okay, good. So there's a little outline on the, I posted it late last night, but it's already on Canvas, all right, for this lecture and the PowerPoint. And the ERD, so again, well, I'll send you the link. I'll send you the link to the ERD when I send the link to the lecture. Okay, if nothing else, then let me stop the recording. And we'll continue on Friday. Okay, Aname and Lisa, see you.
Thank you. Bye.
Thank you.